Inflammatory bowel disease. Ulcerative colitis, inflammation starts in the rectum and only affects the epithelial layer of the mucosa. It is continuous, superficial, and the patient presents with bloody diarrhea and urgency. In Crohn's, any part of the alimentary tract can be affected from the mouth to the anus. The most common involvement would be the terminal ileum and the proximal colon. The patient can present with abdominal pain, diarrhea, and weight loss. It can happen at any age, most commonly adolescence and early childhood. Risk factors for IBD include genetic and environmental factors. Among the genetic factors, you have NOD2-CARD25 gene mutation, which is associated with a younger age of presentation, ileal disease, and strictures. Then there is the autophagy genes, example ATG16L1, IRGM. And then you have the IL-23 mutation. Environmental factors include hygiene hypothesis, which states that because of the ultra clean environment that children are growing in, their immune system is not able to prime the biomicrobes, and therefore they mount a very high immune response to it, causing this autoimmune disease. Then there is GI infections in children, infants that are prescribed antibiotics. Children with vitamin D deficiency are supposed to be prone to it. Smoking is associated with the development of IBD, shown in the Western world but not shown in Asia. OCP use, NSAID use, a Western diet which is high in fat and low in fiber, and depressive illness. MR enterography is the first investigation to be done in Crohn's disease. A coronal view shows mural enhancement, mural thickening, the comb sign, which is engorged perienteric vasculature involving the terminal ileum. Truelove and Witt's classification of severity of ulcerative colitis is mild, moderate, and severe based on bowel movements per day less than 4, 4 to 6, more than 6, blood in stools, no blood in stools, intermittent and frequent, temperature normal, less than 37.8, more than 37.8, heart rate normal, less than 90, more than 90, hemoglobin more than 11.5, 10.5 to 11.5, less than 10.5, ESR of less than 20, 20 to 30, or more than 30. Here we use CRP. Acute severe ulcerative colitis. The lifetime risk of ASUC in ulcerative colitis is 15 to 25%. The mortality is 1 to 5%, and the colectomy rate is up to 40%. Truelove and Witt's criteria says more than or equal to 6 stools per day plus at least one of the following. The temperature should be more than 37.8 degrees centigrade. The heart rate more than 90. The hemoglobin less than 10.5. ESR more than 30. According to ECHO guidelines, CRP more than 30 is what is taken into account. So what do? We admit them, we give a surgery, consult straight away, dietitian consult for exclusive enteral nutrition. We cannot give them anticholinergics, opioids, or NSAIDs. The clinical evaluation is done with a heart rate. We check the abdomen for signs of perforation. We check the blood pressure. We maintain a stool chart with the stool frequency, blood in stools, heart rate, temperature every 6 hours. The tests we do: complete blood count, CRP, LFT, creatinine, urea electrolytes, magnesium level and lipid profile is often missed. It should be done. Abdominal X-ray supine is important to look for a megacolon. Stool routine, culture, and C. diff are done. Fecal calprotectin plus unprepared sigmoidoscopy. plus a biopsy for CMV. We do a Mayo scoring, and a clinical remission is defined as less than 3 stools per day and no bleed. Venous thromboprophylaxis is a must because the risk of developing a DVT is 3 to 8-fold. And if there is a rectal bleed, it's not a contraindication to giving anticoagulation. IV hydrocortisone is given at a dose of 100 milligrams every 6 hours, or we can give methylprednisolone at a dose of 60 milligrams IV OD. And then we monitor their response. It's not beneficial beyond 7 days. According to British Medical Journal 1955, oral cortisone 100 milligrams showed a clinical response in 40% versus 16% placebo. The scores for predicting a response to IV steroids. Oxford or Trans score. Stool frequency of more than 8 per day or 3 to 8 per day plus a CRP that's elevated more than 45 by day 3 gives a colectomy rate of 85%. Ho or Edinburgh criteria, stool frequency of less than 4 per day gives 0 points, 4 to 6 per day 1 point, 6 to 9 per day 2 points, more than 9 per day 4 points. And by third day, if there's 0 to 1, it's 11% colectomy rate, 2 to 3, 43%, 4 to 9, 85% colectomy rate. Abdominal indicators, additional indicators are a low albumin, a CRP by albumin ratio of more than 0.85 on day 3. This predicted a colectomy with a sensitivity of 70%, a specificity of 70% in Journal of Clinical Gastroenterology 2018. That's a CRP by albumin ratio of more than 0.85. A colonic dilatation of more than 5.5 in the transverse colon is checked for, and mucosan islands are seen on the X-ray. On a sigmoidoscopy, we see deep ulcers. You see EIS of more than 7. Fecal calprotectin. The Ho et al. Study showed that the fecal calprotectin more than 1922 micrograms per gram, 80% of them needed a colectomy in 6 months. This was in American Journal of Gastroenterology 2005. A fecal calprotectin of more than 1000 micrograms per gram with a UCEIS of more than 6 and a high CRP were independent predictors of steroid non-responsiveness according to Journal of Crohn's Colitis 2017. We can give cyclosporin instead of hydrocortisone. Initially, 4 milligrams per kg, which showed 82% response rate. The target trough level is 150 to 250 nanogram per ml. A randomized controlled trial shows that continuous IV 2 milligrams per kg per day for 7 days was as effective as 4 milligrams per kg with a reduction in side effects, according to Gastroenterology 2003. The side effects of cyclosporin are AKI, seizures, especially if the magnesium level is less than 1.4, and hypocholesterolemia of less than 115, and a hypertriglyceridemia. Use as short-term induction agent and as a bridge to a long-term maintenance. Infliximab. We have to first rule out hepatitis B, C, HIV, and TB before starting it. We can give an induction of 5 milligrams per kg on 0, 2, and 6 weeks. But we can't give it in latent TB. We can't give it if active severe infection, demyelination, or CCF, according to Gastroenterology Journal 2005. The accelerated regimen can be given at 10 milligrams per kg or 3 doses of 5 milligrams per kg in the first 24 days. The ATLAS study assessed correlation between serum and intestinal anti-TNF levels, and if the mucosa was inflamed, there was less anti-TNF level. That was the ATLAS study, measured A for anti-TNF. High drug clearance in CRP of more than 50, albumin less than 3.5, and a high fecal calprotectin. This was an ATLAS study in Gut 2016. Infliximab versus cyclosporin was the construct trial. There was no difference in the quality of life. The colectomy rate was 29% versus 30% at 3 months, 35% versus 45% at 1 year. Tofacitinib. It's an oral small molecule which is a JAK inhibitor. In the OCTAVE 1 and 2 phase 3 trials, it was as effective as early as week 2, and the dose is initially 10 milligrams BD. We do a surgery if there is a toxic megacolon, perforation, or non-responsiveness to medical therapy. It's a 3-stage surgery. First, there is a colectomy done and an end ileostomy. After 6 months, a J-shaped ileal pouch, an IPAA, is done while creating a diversion loop ileostomy to reroute fecal stream away from the new ileal pouch. And thirdly, the ileostomy is taken down and the fecal stream is restored to the pouch. CMV colitis. The histology shows large eosinophilic owl eye inclusions, which is 92 to 100% specific for CMV. The IHC shows improved sensitivity to 93%. The treatment is IV ganciclovir, 5 milligrams per kg TDS for 3 to 5 days, followed by 900 milligrams BD of valganciclovir for 2 to 3 weeks.